Good evening. Thank you all for coming and welcome to, the name is so long I always forget what it's called, Moving from What to How, Tools for Safe and Effective Opioid Prescribing. My name is Mara Perzer, and I am here representing the Tri-County Overdose Prevention Partnership. And this event is sponsored by the Tri-County Overdose Prevention Partnership. We are a partnership of community organizations, government entities, and private citizens coming together to address opioid misuse and overdose through a multi-pronged approach. And provider education is one of those strategies that we're trying to address. We know that it really is going to take a whole community to address this issue, and we appreciate so much your interest in being here. I would just like to announce that there is one small change to the agenda. Shane Tiernan was unavailable at the last minute, and so Leslie Brooks will be doing that presentation instead, but it is still qualifying for your CME. So that is the important note, and we were unable to actually change the physical agenda, so I wanted to make that announcement. One other little reminder is hopefully everyone signed in when you came in. I apologize for having the 2 sign-in sheets, but especially if you do require a CME, we need you to sign in on the CME one, and then if you are receiving a COPIC point, the other sign-in sheet is asking if you are COPIC insured so that you can get that point. In your folder on the right side is an evaluation form. I would like to really, really encourage you, please, to complete that evaluation form. It will help us. In the future, we do plan on holding similar events and doing additional provider outreach. And so this will really help us understand from you, was this useful? How would you like to be reached? Things like that. And if you are seeking a CME credit, I cannot give you your CME certificate until you submit your evaluation. So at least I know I will get evaluations from those of you who need a CME. And we will have certificates at the end. So when you leave, you can drop your evaluation form on the table and we can get you a certificate. And with that, sorry for all that housekeeping. With that, I'd like to introduce Kelly Lear-Call, who is with Arapahoe County, to give us just a few opening remarks.
Thank you. Thank you. So I would like to, again, welcome you to our program on behalf of the Tri-County Overdose Prevention Partnership. I'm, as Maura said, my name is Dr. Kelly Lear. I'm the Arapahoe County coroner and a forensic pathologist. As a public health physician, I feel like I'm very invested in this as I see the effects of drug overdoses on a weekly basis. In my office, obviously my job is to perform the autopsies, but I would certainly like to see the number of patients I have to deal with decrease through these prevention efforts. Obviously, the busier I am, the more hardship it is on the families and friends of the deceased and on the community in general. From a forensic standpoint, drug overdose deaths are really reaching epidemic proportions on a national level. For years, more people have been dying of drug overdoses than in motor vehicle crashes, and that's a statistic that I think the general public doesn't really get much of, but I think it's very important to highlight because people really think about prevention of motor vehicle deaths, whereas the prevention of drug overdose deaths hasn't quite reached that level of popularity or kind of reached the radar of most people. Here in Arapahoe County, our drug overdose deaths have doubled over the past 10 years, more than doubled over the past 15 years if you go back a few more years than that. And of the cases that my office investigates, drug overdoses comprise 20 to 25% of those. So up to 25% of what I do as a forensic pathologist is drug overdose related deaths. Opiate deaths really drive that. So we've seen a very large increase in opiate-related drug deaths over the years. And now, similar to national trends, we're starting to see the increase in heroin-related deaths as people are turning to heroin because it's so much cheaper when they can't afford or can't get their prescription opiates filled or can't get access to the opiates that they once had. Just for some numbers in general, thinking about what I do, and 25% of my cases are overdose deaths. On a national level, the CDC estimates that for each prescription painkiller death, there's 10 treatment admissions for abuse, 32 emergency department visits for abuse, 130 people who are either abusers or dependent, and 825 non-medical users. So it just kind of compounds, thinking about the death rate, it just compounds with the other people who are affected. And it's something that really affects everybody, and everybody knows somebody who is affected by this problem. So that's why I'm invested in this, in these prevention efforts. Obviously, not many people want to work their way out of a job, and I know it'll never happen, but I would really like to see these numbers decrease. I'm happy to see all of you here tonight as well. Hopefully as invested as I am in stemming this tide of opiate deaths. I think that there's a lot we can learn about safe prescribing, but we also have other tools such as patient education, particularly regarding safe use, safe disposal, safe storage. Those are all things that need to be addressed, as well as the prescribing practices. So with that brief introduction and kind of a little bit of glimpse into the problem it is in our community, I'd like to introduce Dr. Leslie Brooks. She's the Chief Medical Officer for Sunrise Community Health, and will get us started with the actual program.
Very much. Appreciate that. Welcome. Yes, thank you. Thanks everybody for being here. We've been doing this sort of road show for, well, hello, Dr. Douglas. We've been doing this roadshow for probably about a year and a half, roughly. We've done several full day CME, day and a half CME, and then morphed this into sort of more bite-sized components. But before we go further, tell me who's in the room. How many prescribers in the room? MDs, DOs, NPs, PAs. Okay, nurses. Great. Behavioral health. Okay. Pharmacists, dentists, veterinarians. All right. Which one? All right. Cool. Great. Did I miss anybody? Great. So hopefully there's something for everybody in our program tonight. The program pretty much runs itself, and we'll introduce ourselves as we go. But I will introduce Dr. Steve Wright. Steve is a family medicine physician and addiction medicine specialist, and he has been practicing for ever, long time. So here you go, Steve.
Thank you, Leslie, and thank you, Dr. Weir, for your comments, too. This is really an important area. So, hi, my name is Steve. I'm a recovering opioid overprescriber. Hi, Steve. You know the drill. All right, let's try it again. Hi, my name is Steve. I'm a recovering opioid overprescriber. Thank you. Oh, my gosh, this is really pitiful. But it's really true, you know, and a big part of the problem is that I'm an underprescriber as well. We did not know as we went along to whom we should deliver enough or more, and to whom we had delivered too much. So I grew up in family medicine, residency trained in Fort Collins, 1982, and then I started doing addiction medicine in 1987 when I was in Santa Fe, New Mexico, and there a group came down actually from Colorado Springs, wanted to put in a treatment center for addiction, and I said, well, sure. I was young, I was hungry, I needed work. I said, I have no training, no experience, I didn't inhale, I got the job. Loved it, and I love doing this work, particularly with addicts, and been doing it now 30 years this year. And then started doing medical pain management about 14 years ago, when I found that a lot of individuals with addiction had a lot of problems with pain. And at that time, pain centers were really more procedure centers. I wasn't getting the answer that I was looking for. I love the neurophysiology of all this and how this applies in real life. I'm the kind of person that wakes up in the middle of the night. What's the anterior insula saying to the posterior insula? You know, the voices, right? Val? Yeah, she hears those voices too. But it's true. I'm very interested in all that. My daughter, who was very much aware that something was wrong with Dad, came up to my wife when she was 7. She's 27 now, came up and said, Mommy, is Daddy a nerd? And she said, yes, but we have to deal with him. So, but it's really true. You know, the neurophysiology is not this abstract thing. It has to do with how do we engage in the lives that are totally disrupted either by pain or addiction for these individuals. And we become involved and sometimes overly involved with the use of medications for a lot of these individuals. A lot of these individuals, their lives are built up around pills. And it's not just when it comes to pain management, but to other things too. And how do we deal with encountering these individuals in our medical practice and taking care of them? So I want to talk about opioid prescribing, a little bit on the prescribing part, but also the risk management part, and somewhat about addiction as well. These are my disclosures. It's true, I work for the dark side. And I want to thank, in particular, North Colorado Health Alliance and the Colorado Consortium for Prescription Drug Abuse for all of this. We are going to talk about the need for opioid risk management, a structured approach to managing opioids, and an approach to dealing with the aberrancies as they show up, and then how to document that. So it starts off with pain. And Albert Schweitzer really described it very well. Pain, a more terrible lord over mankind than even death itself. These individuals are truly affected in a bad way, and there are many, many consequences. And I'm going to be running through these slides pretty quickly because we only have so much time. But I believe we have a thumb drive for everybody. Is that correct? That you can look these things up, and you can look up the references as well. You don't have to believe anything that I say. So very expensive, lost work, inadequate pain, acute pain care can lead to chronic pain. And I think it was Nietzsche who said, "Love your don't work." I'm sorry, Nietzsche, who actually said that if it doesn't kill you, it'll make you stronger. That's actually not true when it comes to chronic pain, because we do know that inadequately treated pain can lead to chronic pain. There's an interesting study out there, circumcision. Kids that have had circumcision have more immunization pain than kids that don't. So there is some importance. Now, the problem with what we were doing in the past is we made an equivalence between pain and opioids and said everybody had to have opioids. That really isn't true as well. But there are significant consequences. Mental health, depression, suicidality, a doubling of the suicide risk, decreased function, pain interference, issues around disability, and the chronic pain really is undertreated, and we need to address that. So we've actually had available to us the opium plant for many, many years, 3400 BCE. The Sumerian name for this plant, plant of joy. Opos was Greek for juice. So it's been around for a while, and our pharmaceutical companies glad to help out where they can. And you can see here that heroin by Bayer Pharmaceutical. I love this, love the part where it's produced in Stone Street in New York. And then, of course, Sears and Roebuck, happy to help out in the late 1800s. You could buy this through their catalog as well. So we're having a little trouble here. But we don't want this. We don't want the perception among our pain-treated community that it is indeed a happy hour event for them. We are there to take care of their pain and not the other issues. And so even the wonderful Wizard of Oz addresses this. She forgot where she was, fell asleep among the poppies, fell fast asleep. What shall we do? Asked the Tin Woodman. If we leave her here, she will die. And indeed, that is what happens some of the time. So are we in a phase where, as Will Rogers says, good judgment comes from experience, and a lot of that came from bad judgment? And I think we really are learning along the way, because indeed there are not only consequences to chronic pain, but to opioids as well. We had diversion, misuse, non-medical use, addiction, overdose, and overdose death, but many other things as well. Probably the most prominent of which is the opioid bowel dysfunction, constipation. And then we have to be concerned about what is our philosophical background in terms of how we deal with this. Hippocrates theoretically said primum non nocere, which is a lie in a couple ways. First of all, he's Greek, and that's Latin. Primum non nocere means first do no harm. We don't do that. We do harm every day. I do economic harm to every one of my patients. I give them medications with side effects. We give them refills of the medications with side effects if those side effects are manageable. What we really do is we do less harm. And that's what the intention is. We cannot simply hide behind do no harm, do no opioids, because indeed we do some harm for individuals who need pain management through the use of opioids. So we're stuck. We have dual problems that we are faced with. We have the 100 million individuals that do have chronic intractable pain and about 25,000 overdose deaths. A very big deal. So we get torn in both directions in terms of what we're looking at. If pain is not reversible, and it's important to look at how do we reverse pain, it's better to take out the appendix than to use oxycodone, for example. But if we can't reverse that with a procedure or otherwise, non-medication approaches, medications that includes non-opioids as well as opioids, and it's all about how we end up with function. It is true, we want to find out about what's happening with the pain, but the function is the end game. The analgesic benefit is the signpost along the way. And we want to know what the evidence says and what it does not address. So we're not going to go through all these, fortunately, but there's a lot of studies out there in terms of the short-term pain management and intermediate term studies that really show that opioids do work, but do note they may not necessarily work better than other things. Non-opioids better than equal to opioids in non-cancer pain, non-opioids equal to opioids in low back pain, and so forth. They're actually functional studies as well, and it's simply not true that there are no function studies out there. And you can see here that again, opioids and non-opioids are compared. There is benefit to these as well. What about long term? By that meaning greater than 6 months, and it really is true when you look at the CDC review that there is no study that's placebo-controlled that says that opioids are effective beyond 1 year. The problem is that you can't really do a study that way because it's unethical to do that for chronic pain at the severity level. However, there are several review studies underlined in blue which do show there is some efficacy over time. And you can see here open-label studies with regards to a variety of agents as well, showing efficacy for opioids. And so I want to step away from that, but I want to make sure that the message is delivered that opioids may have a role in certain individuals over time. So there are times in which we may be under-prescribing when we should be prescribing, but we are here primarily because of the risk of over-prescribing, which is a very big deal. There are several reasons. I mentioned one, the the inability to do a placebo-controlled study over a 1 year period of time because of pain severity. Some of the studies actually put a level of efficacy required to be successful as too high. There are significant genetic variations where I might not be responsive to a particular opioid, and there aren't exclusion factors in that regard. And probably the biggest one out there is the absence of naturalistic studies. And by that I mean, in pain management, we don't simply try one opioid and then give up. We rotate from one to the other, and those kind of studies really have not been done to any significant degree. So, trouble, lots of trouble. There's diversion, which means transfer from a lawful to an unlawful channel, misuse, use in a way other than intended, non-medical use, use for a reason other than intended. And I prefer to use that term over abuse because abuse certainly tends to imply that you know what the particular motivations of the individuals are. And then addiction, of course, is really central. It's compulsive use with negative outcomes, overdose and overdose death, and these are related to respiratory depression, and in the case of methadone, torsade de pointes, which is a rhythm disturbance that can occur because of its effect on the heart. We're not going to get into a lot of that. So what are the numbers on that? Dr. Weir spoke to some of this. We have 5% of the world's population, but prescribe 80% of the world's opioids, 99% of the world's hydrocodone. So either we're doing something, we're way ahead of the curve, or something else is going on. And I would suggest the latter is the case. Diversion is important. We see Individuals on the PDMP, the Prescription Drug Monitoring Program, about 0.7%, accessing more than one physician, actually more than 5 physicians at that particular cut point, and there's a strong association with overdose deaths there as well. Misuse, about 20% of the opioids we prescribed are misused by patients. This is actually down since the year 2000 on a regular basis. And on the other hand, addiction is up. So there seems to be a more rapid transition that occurs in our culture now from non-medical use to addiction. We have now about 2 million individuals addicted to prescription opioids. And of course, we've heard about heroin being up as well. Enormous cost to us all. So the language does make a difference. Again, abuse is pejorative. I prefer non-medical use. Dependence is somewhat ambiguous. I'm dependent upon oxygen. If you take that away, I don't do very well. If I'm on a beta blocker for high blood pressure, you remove that, I may not do very well as well. So dependence or reliance upon a medication is not exactly what we're talking about. Physical dependence is certainly the term that applies to tolerance and withdrawal. And another thing is that I think is really important in language is how we speak with our patients and speak about patients in other contexts. And I'm just learning this over time, the person-first language. So it's not an addict, but a person with addiction. It's not a disabled person, it's a person with a disability. And that does a couple things. First of all, it emphasizes in that conversation that I know you as a patient are so much more than the addiction that you have. And that actually is transformative for me as well, that I start to understand that this individual has broader skills, broader interests, and a part of life that is so much more meaningful and important than just the singular diagnosis. No wonder our patients feel that we label them as well. And it was Osler that said way back in the day, more than a century ago, much more important to know what sort of person has a disease than to know what the disease the person has. So addiction, not a basic drive in every individual. It is not the same thing as physical dependence, not to be confused with pseudo-addiction. Pseudo-addiction refers to, I come in, I'm having terrible pain, and I'm pushing you for more opioids. In that context, it's very difficult for us as medical providers to sort through all that and say, yes, that's about pain and not about addiction. But that push for opioids goes away once an adequate analgesic treatment program has been placed. The chronic disease of addiction is a disease of the brain reward system. Compulsion, thinking about it all day long. Loss of control. Today I'm going to have 2, but actually have 20. Continuation in spite of adverse consequences. I get loaded, I plow my car into the tree, I swear I won't do it again, but then I do. Or something similar, come off a roof or something like that. It is not voluntary. There is distinct neurophysiology. There's a lot of overlap with pain and a lot of the mood disorders. It seems to be genetically based in about 60 to 80% of individuals, environmentally influenced. It's not curable. It is a chronic disease, but we tend to think of it, you go to treatment, you ought to be okay, but no, you need to manage this on an ongoing basis. And it's identifiable by screening, which can lead to the diagnosis. And we use the various treatment processes, including mutual health programs, addiction therapy, and medications. It has a predictable course if treated, a predictable course if not treated as well. And this turns out to be the case in about 10 to 15% of individuals that are on chronic opioid therapy for chronic pain will have the disease of addiction, and our job is to sort that out. The overdose picture has really been changing over time. We start in 2002, and as you can see, the red develop. It really is disarming to see how the overdoses have kind of overwhelmed our country. And in the year 2009, that was when the lines crossed over for car crash deaths and opioid deaths, and we have sustained increased opioid-associated deaths since that period of time. Here we are in the Tri-County area in 2002. This has gotten to be even worse. And you can see here only Mineral County in the state of Colorado has not had the increases that we're concerned about. You can see here the lines as well with heroin and prescription opioids. we thought between 2010 and 2013 we might be bending the curve. That actually might be the case in Colorado. From 2015 to 2016, we had a drop in overdose deaths from 472 to 442, probably from a variety of things that we're doing. But you can see here, in general, we have not been successful across the country in dealing with this. So what are the risk factors that are involved? Any opioid prescribing. The opioid-associated death rate is among those that receive an opioid anywhere from 0.02 to 0.06%. Of those receiving opioids. We can't simply just hand the baton over to non-steroidals because you can die from those as well at about a 0.02% rate from GI bleeds alone. So we need to risk manage those situations as well. And as the dose of opioids increases, there's a linear increase in associated overdose deaths. But I want to point out here, too, that 44% in one study had no in one study, 44% of individuals who had an opioid-associated death had no written prescription for an opioid the previous month. So we can't be cavalier and say low dose is okay or no medication is okay. We've got to be watching out for these individuals as well. One of the studies looked at an overdose situation, and 91% of those individuals that had an overdose received another opioid by prescription. We shouldn't be doing a lot of that. 17% of those individuals had repeat overdose. And we need to be particularly concerned about co-prescribing sedating medications, particularly benzodiazepines, and of course using naloxone to help. We don't know if risk monitoring and management makes a difference, but the risk management principles are risk assessment, risk mitigation, risk monitoring, and aberrancy management. I'm going to run through that. So the assessment involves a risk evaluation and then risk stratification. What are the primary risk factors? They are personal and family history of substance use disorder, a personal psychiatric history, and a personal sexual trauma history is really important. We then want to ask them about their current use. SBIRT is the way to do that. The prescription database also is another way. And also to do a urine drug test to see what they're taking today. There are screening tools that we can use. I think the SOAP has the best validation. And of course, we want to pick up the old medical records as well for these individuals to see what's going on. Then we stratify the risks. Are they low, intermediate, high risk for controlled substance use? And then mitigate. Risk mitigation refers to what are the prevention strategies going forward? How do I limit the downstream risk for these individuals? First of all, we want to spare opioids in the first place, find the pain generator and fix that. No opioids for certain pain types. That certainly is true for headache. It certainly is debatable with regards to fibromyalgia. It's not first line, however. Non-opioid approaches, and then the dosing thresholds may be something that we could talk about, but not at this particular time. There are a variety of calculators out there. I recommend the Practical Pain Management Calculator, and the reason is that it's probably the most science-based of all of them. There's about a 300% difference between the various calculators, and as you try to address the level of risk for your patients with these morphine dose equivalents, you may be off the mark depending on what kind of a calculator that you use. Other ways to look at that, perhaps abuse deterrent formulations, and a controlled substance agreement is really central to all of that. Behind all of this is the informed consent. What are the risks, the benefits, how to use the medication, what are the alternatives? You want to set the goal for pain and function and make that personalized to the individual. And medication security, safe storage, a lockbox, not with a key that can somebody else can open things up, but with a combination. And I would tell patients, if you can't remember the combination, you probably shouldn't get in. You're probably taking too much. And then disposal. We got to get rid of the medications that were not used. There's a bill before the State House at this time looking at partial fill prescriptions. I think this has value so that when I'm dealing with an acute pain situation, I can give a prescription that might be 10 days long, but I can say just fill the 3 days because that might be all this individual needs. We do know that the majority of individuals that use opioids on an acute basis do not use all their opioids, and they sit in cabinets available to the neighbors and so forth. And then, of course, naloxone for rescue from overdose, and we have seen hundreds of saves here in the state of Colorado, maybe one of the major reasons why we are starting to bend the curve. So we establish the goals, establish the plan, provide patient education, establish the controlled substance agreement, take the leap with the opioids, and then follow up. And they're the 5 A's that we look at. What is their function? Are they improved with regards to their pain, their mood, adverse events, and what about the aberrancies in relation to the opioids as well? And what I paid attention to in particular were the medication change requests and how emphatic patients were in relation to that, because sometimes that's a cue about a problem going on. We want to make sure that the function is what's improved, and individuals may have improved function without a change in pain because they've increased their activity level to the same level of pain. So they've increased their activity level, but they might still have a 7 out of 10 pain. And if they're happy with that, I'm happy with that as well. The analgesic efficacy is really quite important. This is the intermediate goal. I know some practices choose not to use analgesia, but I think it's a good signpost along the way. I mean, when you think about it, we're not really looking, when you're looking at osteoporosis, we're not looking at bone density as the end game. The real end game is fracture rate, but we use the intermediate value of bone density as a goal as well. Is there any analgesia? How long does it last? And is it durable over a period of time? And then what the side effects are. As I mentioned, constipation is the bigger one. We monitor then our patients as we go along after they're established on opioids, the behavioral aberrancies, the online prescription database, the urine drug test, and sometimes a pill count. So I've collected some reasons why patients have had medication issues that I'd like to share with you. Sorry I'm late. I got arrested. I'm in a rush. I need a refill. I was eating Percocet over the sink when they fell in. I think anybody that uses Percocet as a food product may have an issue. The deer ate them off the picnic table. I lost my pills when 3 trees fell on my house. Oxycodone, my urine, that can't be, but I did have sex with my husband who takes it. Remember that, Val? You can't make this stuff up. I buy these syringes because my trainer tells me to inject B12 4 times a day. My parakeet carried the bottle out the window. I don't know how they ended up in the microwave. They fell on the floor. All these ants carried them off. All I could do was watch in amazement. And my favorite was, you won't believe this, I took off fast. The pen popped off the dash, hit the prescription lying on the car seat. That's why there was a 1 in front of the 20 Vicodin by the time I got to the pharmacy. What could I do? Well, what could I do? What did the Ukrainian judge give you? I mean, you can't make this stuff up. So the clinical skills that are involved here involve motivational interviewing. And I think this is a really important skill. And the key element within that, as I see it, is have the patient define their goals in life. Have the patient outline their current behavior. And let them make the link or the absence of a link between the two. Somebody sitting there still smoking, using oxygen, is going to think about, well, maybe that goal of being able to go to my granddaughter's graduation from high school is not realistic. Can you help me? That's what we want to do. How do we deliver the information to individuals that are overusing? Well, I don't necessarily say you're an addict or you're a person with addiction, because I don't quite know that a lot of times, but I can no longer deliver this medication into an uncontrolled environment. And then finally, my favorite, No is a complete sentence. We get into this endless debate, no, because, and then the patients will debate that. So I'll do the no because and explain why, and then I'll do it a second time in case I wasn't clear. But the third time, no and a big pause, there's nothing to debate, because one of the most difficult things that we have is how do we end the office visit if we're not going to be writing a prescription for this individual. And then finally, I think it's really important to understand our biases. We all have them. Anais Nin said, we don't see things as they are, we see them as we are. And we may be, we need to understand our own bias. Do we inherently trust or distrust patients when we shouldn't? Is there an inclination to overtreat or undertreat? Understand your bias. Understand that you want to run interference on that bias. Trust but verify what's going on there. And so the whole idea is not necessarily let's get rid of all the opioids, is enough but not too much, and for a certain segment of our population, none at all, and we need to move them off of standard opioids into a treatment process as well. When we document, you want to document this under each section: pain and function and risk, subjective, objective, assessment, and plan. Put those variances together. What we do know is that individuals that have 4 or more variances are not likely to be successful going forward in the future with chronic opioid therapy, and a change of plan is indicated. And you want to put in your medical decision making as to what you're doing. But let's not lose sight of the patient. I love this by Naomi Wolf. Pain is real when you get other people to believe in it. If nobody believes in it, it's madness or hysteria. We've got to listen to our patients. And there are about 4 gravestones around the world which have these words: I told you I was sick. And it's really true. We need to listen to our patients in that regard. Jane Ballantyne said efforts to address abuse should not interfere with the legitimate medical practice and patient care. But we do have to be careful. I think possibly the best poet ever, and probably was an alcoholic, was Rumi in the 13th century. And he must have been an alcoholic to say these words. The wine that we drink is really our own blood. Our bodies ferment in these barrels. We'd give up everything for a glass of this. We'd give up our minds for a sip. Soul drunk, mind ruined, these two sit helpless in a wrecked wagon. Neither knows how to fix it. But my heart is more like a donkey mired in mud, struggling and sinking deeper. That's true for alcoholism. That's true for opioid addiction, and it's also true for our patients with chronic intractable pain. We need to be there for them. And thank you very much for your attention.
All right, virtual impossibility for me. Walk, chew gum, two things at the same time. We'll see if I can manage. All right. So I didn't know there was going to be a dexterity test to fail. Thanks. And again, as the others have said already, I really appreciate everybody showing up tonight and coming out for this program. It's tremendous. And thanks to Mara and everybody at Tri-County and John and everybody for hosting. Really appreciate the effort. It's something everybody in everybody's community needs to address. My name's Rob Valek. I'm a professor of pharmacy and epidemiology and family medicine over at the university, the place that you can get to in about 45 minutes. If you, at least coming over here is about, if you don't follow me, because I know all the bad streets where the traffic goes into the construction. So, no, but I'm right over there at CU. And I coordinate our statewide effort, the Colorado Consortium for Prescription Drug Abuse Prevention, of which there are many different focus areas that we're working on. One of them is provider education like this, but we do a lot of other stuff with legislation and guidelines and some of these things we're talking about. So I'll talk a little bit about the next piece of this. Steve spoke about clinical pearls for safe prescribing, and he's, one of the better, comprehensive levels of understanding of anybody that I've ever met is Steve in terms of pain and addiction and the interplay with all of these things. So, following those clinical pearls, we're trying to add on a layer now of, all right, what do the laws say? What must I do? And then what do regulations say, what may I do? And what do guidelines say, what should I do? And those are different kinds of things, but there's a lot of that out there now, as you can imagine. With all the attention to the opioid epidemic, there's a lot of stuff coming out in laws, regs, and policies and guidelines that it's kind of worth going over, we think. So by way of disclosures, these are mine. So my objectives are first to talk a little bit about what's going on at the federal level, not a whole lot, but just each of these, because again, I got 20 minutes. So a little bit about what's going on at the federal level, a little bit about what's going on at the state level as well, and then kind of try to differentiate along the way about what is law, what is regulation, what is guideline or best practice, and so more the suggested or recommended things versus the mandatory. I've covered a little bit of this already, so I won't talk a lot about it. And someone actually basically, it was perfect. Reading rooms in the same data. It's nice that I can find the same place at CDC that you did. It's comforting to know that we look up, try to find the best numbers, and there they are. But you can see the staggering impact of the epidemic on society has already been described. The cost is estimated to be up in the neighborhood of $600 billion a year. The cost impact is just tremendous, and for employers, and there's that angle. Most of the cost to them is in lost productivity for people and the families and people themselves. It's not just the direct medical cost, but equally sizable is lost productivity and impacts on families and communities. Provider liability is also increasingly an issue. It's not directly the topic of this talk, but if you talk to folks like Alan Lembitz over at COPIC, they will tell you that they are very nervous about provider liability issues because lawsuits now are becoming increasingly common, both against providers of all kinds, physicians, pharmacists, but anybody involved in providing care for somebody with an addiction. And some of those lawsuits aren't just for malpractice in poor treatment of the addiction, but now the lawsuits are, you allowed me to become addicted. And it's a very different kind of thing to say, you allowed me to have this other thing happen to me. We don't see people doing that. You allowed me to get diabetes from my prediabetes. Or you allowed my hypertension to become brittle, so therefore it's your fault. Or you have some culpability. Now lawsuits are happening. West Virginia is letting them go through. They were held up for quite some time at the Supreme Court of West Virginia, whether they tried to decide whether it was okay to let those lawsuits go through. And they've decided, yes, it's okay. They haven't awarded judgments or anything yet, but they're letting the lawsuits go through against pharmacists and doctors for you shouldn't have dispensed this, you shouldn't have prescribed it. So you let me get sued. So I think it's important from the liability standpoint to understand the laws, regs, and guidelines out there, because increasingly the guidelines, even the recommended stuff, are things that lawyers are looking at. I was in San Diego for a vacation. I know people that are in the room that know me well won't believe me that I was actually on vacation. But I was on vacation once, way back, like a whole year ago. And I was in San Diego, and I walked into the lobby of the Marriott. I'm walking down with my flip-flops and my Hawaiian shorts, getting ready to go surfing. I wasn't. But I'm walking down through the lobby trying to find my room, and I see that the American Bar Association is having a meeting, and one of their health, medical malpractice sessions is going on. Opioid misprescribing and how to identify poor prescribing doctors. I thought, holy crap. So the lawyers are aware, and they're also aware of guidelines being out there. And so there's things to keep in mind. So even if it's just from the sheer standpoint of fear and CYA, then whatever the motivator is, I think all of them are at play. So what's being done? A lot of things are happening. Attention is there. You can't pick up a paper. 5280 magazine, so you're in the checkout stand at the grocery store. You pick up the copy of the Denver Post. You turn on the TV, NPR, you name it. Somebody's covering the opioid and heroin epidemic, and which is good in many ways. The attention is rising on this. So there's a lot of things happening. I'm going to talk a little bit about these, federal and state stuff, guidelines, and then you'll hear more about ECHO and some innovations near the end. So from the federal level, what's going on? All the agencies are trying to do what they can within their scope of statutory authority. The DEA has taken a much more aggressive stance with scheduling drugs. So they're up-scheduling things, moving things from lower schedules, like, for example, tramadol was not scheduled at all, and they made it a scheduled substance. So with at least some degree of addictive potential and therefore requirements that go along with any controlled substance versus just a regular legend drug. And the hydrocodone combination products, Norco and Vicodin, were moved from Schedule 3 to Schedule 2 as well. This is a couple of years ago now, but that was a pronounced shift in that because those are moderately potent opioids being moved up into a kind of regulatory framework that the most potent opioids typically occupy. And it made it hard. So no refills, everything you have to be seen again, that kind of thing. And the motivation, I think, again, was make it a little bit harder for people to continue to get these things without seeing a physician. So you shouldn't be able to get 6 months worth of Vicodin without going back to see the doc. And that's not an unreasonable, I think, motivation. It does cause other issues on its own. So people say, is that a good or a bad thing? It's inconvenient in one way and it's perfectly helpful in another. So it's not perfect. It depends on who you ask. The DEA's also worked on take-back on the back-end side regulations, even though they don't really have anything to do with product other than keeping track of where the product is going through distribution. They've been much more active in take-back. They just had the 13th event last Saturday, of course, in the middle of the snowstorm. They have a take-back event. But they collected here in Colorado about 20,000 pounds of medications were collected, even in the driving snowstorm. Last spring when they did this, last fall when they did this in October, it was more like 30,000 pounds. So partially they think that's part of the weather, but they had an interesting control group this year. There were some 9 health fairs going on at the same time that reported double the size of the audiences showing up at 7 o'clock in the morning in the middle of the snow at the 9 health fair. So we think that the weather may not be the only factor. People are thinking now, and a lot of the law enforcement agencies are saying people are starting to come in between to the take-back sites that we have started to put into communities, and that we're using those more. Law enforcement is getting more involved in ongoing take-back of medications, which is good. And DEA enabled that by creating laws that allow pharmacies and law enforcement agencies to be what are called reverse distributors. It used to be prohibited by federal law for a pharmacy to take back an opioid. When I practiced pharmacy many years myself, people would say, I want to bring these back. These are dangerous. Sorry, I can't help you, which is really kind of perverse when you think about it. But now it's okay. Pharmacies can do this, and many of them are doing this, which is a good thing because we know that over 70% of people that abuse opioids start off in the medicine cabinet of a family member or friend with medication that was not for them. So the single largest piece of low-hanging fruit to address the epidemic is to lock stuff up, don't let somebody else get it, and dispose of it when you're done. So all of our public awareness messaging is safe use, safe storage, safe disposal, because we could address 70% of the people getting into problems if we just did that. So it's really rather striking. So DEA's, they're on to something there as far as safe disposal and wanting to push that. The FDA, they've had REMS programs, risk evaluation and mitigation strategies programs for a number of years, and have required manufacturers of opioids, especially the extended release and long-acting opioids, to create programs to educate docs. And if they don't hit metrics on the numbers of physicians trained and demonstrating pre-test, post-test knowledge acquisition, which isn't a perfect thing because I can do really good in a test right after you give me the information, and 2 weeks later I might not remember who you were, what I had for dinner, after today. But at least the pre-test, post-test, and to do that, and that's been helpful. A lot of physicians have been trained over the United States, but we think there are somewhere between 800 and 900,000 physicians that need training of some kind, and we're thinking that the REMS programs have probably reached maybe a quarter of them. So it's, even with an FDA mandate, and the manufacturers having to do this or risk having action taken against their products, it's still very hard to do. So, here we are. We're doing this, as many times as we have to do this. Leslie and Steve and Ricardo and I joke. But as many times as we have to do this, we will, because we need to get everybody educated. They also approved single ingredient opioids. So these are not combination products. So it's a single agent hydrocodone by itself, which some people think is a wonderful thing. As a pharmacologist, it's a wonderful thing. I want to be able to give you only the drugs I want to give you, and not other ones like the acetaminophen or whatever that's riding along causing its own problems. So pharmacologically, I like that. As someone who's trying to deal with abuse and diversion and all those kinds of problems, I'd say that's another problem because people are going to seek these out even more so because this is pure, hydrocodone. It doesn't have all that wacky acetaminophen that I don't want. I want the opioid. So it's good and bad, depending on each one of these things I think has a place, and it's a help in some ways, and it can be a detriment in others. Abuse deterrent formulations, industry has given guidance. There's kind of a misconception out there that all new opioids must be abuse deterrent. Not true. The FDA will approve non-abuse deterrent formulations. If a company wants to claim in their label that their product is abuse deterrent, which I think is an advantage to a company to do that, they must meet certain guidance and certain criteria to make a claim of abuse deterrence. That's really FDA's position. So that's why you will see some new products that are abuse deterrent and others that are not. It's not a requirement. It's only an option. The Department of Health and Human Services, outgoing Secretary Burwell, at the current time, I can't tell you about the incoming administration or what may or may not happen or what the position may or may not be, because I don't know any more than anybody else does. What that's going to be, don't know. But the outgoing secretary made priorities, basically naloxone access at the top of the heap, second, provider education, and third, increased access to treatment. And the monies that have been flowing from the federal level lately, CARA last year and 21st Century Cures early this year, most of those monies, about 80% of those, are dedicated to increasing access to treatment. Colorado is receiving $7.8 million this summer from 21st Century Cures, 80% of which within 3 months is supposed to start flowing out the doors of OBH for providing treatment. So that's good, but again, you talk to people and say, well, what is $6 million going to do in terms of treatment in Colorado? And I said, that's not enough for Arapahoe County, or Adams County, or Douglas County, it's not enough for a county level type of thing to get $6 million, but it's a start. And I came from meeting with Senator Bennett yesterday downtown saying we need more. $8 million isn't enough. $8 million per county is what we need to start with. We need hundreds of millions of dollars to try to expand treatment is what we need. But that's what they're trying to do. Again, lifting the cap on buprenorphine prescribing, which is kind of a non-issue. Most docs will tell you it's not the cap. It wasn't the, I'd love to go from 100 to 275. It's that I can't do this. There's no behavioral health access for me to be able to find people to help do the behavioral components to do this. I can't build an MAT practice because of other problems, not the cap going to 275 or not. But it was done anyway, so at least maybe it's a small hurdle removed, but that's what the HHS has been doing. The CDC, as you're probably aware, how many of you did know that CDC had issued a prescribing guideline for opioids for chronic pain? How many of you have read that guideline so you can tell me what the components are? And it's very common. In fact, you're different because, again, you're self-selecting to come to a program like this. You have an appetite to learn more about what's going on. So it's kind of it's good, but most docs aren't even aware that the CDC issued guidance. And so it's really something that people don't yet know about. But they have created this guidance for prescribing for chronic pain, and it's generated a lot of controversy. People think for everything from CDC shouldn't be in the guideline business unless it's telling me how to do infection control and universal precautions for infection control because, damn it, that's what the CDC is for, tracking infections, right? You're not supposed to be telling us how to treat chronic pain. It's not your job. So there is that argument. But again, CDC believes it's within their statutory authority, and if you look at statute, it probably is, to advise on best evidence about things that have public health impact. They've declared this a top 4 epidemic, cancer, heart disease, obesity, prescription opioid abuse as a top 4 epidemic. And so they said, well, if it's at that level, then we have to do whatever is within our statutory authority to try to address it because we can't just let that go by if we think it's that serious. It's a leading cause of injury to death, as the epi folks and the public health folks in the crowd already know that it's a serious issue for the country. So CDC is involved. The state level, a lot of things are happening as well. I didn't even put stuff that's, because I had to submit these for CME approval several weeks ago. There's 6 additional bills at the legislature since these were submitted these slides 6 weeks ago. So there's a lot of activity at the legislature. Things that have happened is our PDMP has been enhanced, or the law anyway has been, so prescribers and dispensers, both sides, have to have an account to use the PDMP, do not have to check it or use it. But mandatory checking is now in effect in states that cover more than half of the physicians and patients in the U.S. California just flipped, so now it tipped the scales to mandatory checking is more common than not. More physicians are under that requirement than not. And Colorado's legislature considered it this year, but did not put it through. I would expect next year you will probably see a mandatory use law. I'd be shocked if it doesn't come here next year. So it's coming. So they're trying to work with the Medical Society and other organizations, whether it's Workers' Comp or Medical Society or Pain Society or DORA, to try to increase awareness of the PDMP and try to drive up use as much as possible, and maybe argue that the mandate isn't needed, but it's probably coming. But you can do delegated access, so a physician or a pharmacist can delegate up to 3 people to look things up for them. That's at least a potential help. So that's good. They do unsolicited reports called push reports. So if somebody's meeting criteria, usually it's a whole bunch of doctors and a whole bunch of pharmacies. They don't even tell me the numbers, what they are, so I can't go out there and blab around and let off, tell people where it's like telling people where the speed trap is, right? So they won't tell me what the numbers are. But if it's going to a lot of doctors and a lot of pharmacies, then you'll get a letter as a provider saying, you might want to check the PDMP. You have a patient who is meeting criteria that could be a doctor shopper. They don't tell you what you don't have to act on it. There's no statute that you have to act on it in a certain way, but letting docs know. And those have, every time those get sent out, month after month, they start to go down. So we believe there's some evidence that doctor shopping is decreasing a little bit over time. So that's a positive. We have all three of the trifecta of naloxone laws that are believed to be best practice around the country. One of them is a Good Samaritan law for immunity from prosecution. So if someone calls 911, they won't be prosecuted if they only possess small amounts of drugs that wouldn't be enough to classify them as having the intent to distribute. Innocent bystander law, that a physician can prescribe for someone else other than the intended recipient of the naloxone. So you can prescribe for a family member and say, you may now have it with this prescription to use for your loved one, neighbor, friend. And even better, sort of superseding the need for the second one, was a standing orders law passed 2 years ago that basically allows a physician to issue a standing order, and then a pharmacy can use that standing order to give out naloxone for whoever they deem appropriate within the context of that order. And when that was passed, the next day, in May of 2015, Larry Wolk at the State Department of Public Health issued a prescription for the state of Colorado. So you may not know this, but you have a prescription, and so does Steve, and so do I, and everybody has a prescription in their name under citizen of the state of Colorado. You have a prescription for naloxone on file at the CDPHE. Your pharmacy only has to avail themselves of that standing order and request on a Google Doc that takes seriously about 15 seconds to fill out. They just do a quick verification that, yes, that's really a pharmacy in Colorado, and yes, that is a pharmacist, and they do some quick checking. Then they issue the standing order, and you can go now to over 430 pharmacies in Colorado and walk in the door and ask for naloxone under standing orders and not have to go in with a prescription. So it's the next best thing. We did our very best to skirt federal law and not, because I've been asking FDA, I write letters like in the Shawshank Redemption, with Tim Robbins. So we want books, so I write a letter. We want OTC naloxone. And I've been sending these letters to the FDA, and some of them bounce back, and occasionally I get like a visit from somebody that says, you stop writing letters to us. But I keep doing it anyway. I figure like 6 years. If I can beat the Shawshank Redemption, that's my goal, is to try to get naloxone over the counter. But until then, we have standing orders, and you can walk into a pharmacy. And Safeway now is starting to advertise. If you walk into some Safeways, you'll see the little placard on the counter, naloxone available here. Ask us for naloxone. And they're telling you about it when you're walking by. So you can see that and walk up to the counter and say, I'd like naloxone under standing orders, and get the naloxone. So it's a fantastic development. It's the best thing we could do than putting it. I think it should be out in the hallway next to the defibrillator. There ought to be a little case with naloxone everywhere you go. Because if you're going to let me hook you up to a defibrillator and apply some joules to you that way, if you're going to let me do that, it's really, naloxone's a lot safer than a portable defibrillator is in terms of safety. We have an abuse deterrent formulation bill a couple of years ago. It turned into, it was asking this to be required, that pharmacists dispense these if physicians wanted, and mandating that insurers cover these with no co-payments or with no prior auth requirements or anything like that. And so a lot of people got into a lather about the requirements, of course. And it became something that we studied, and Steve chaired the group that studied abuse deterrent formulations and what's the current knowledge about abuse deterrent formulations. And the conclusion really at that time was we need to learn more about the place of ADFs and where they are before we would legislate some sort of mandate or anything like that. That it was the evidence doesn't support much yet in terms of what should be mandated. So right now there is nothing from that. There's an expanded medication take-back program that we have that we, again, requested 2 years ago funding from the JBC. It was like this time of year 2 years ago. We went in May, right before they submitted the long bill, and said, oh, by the way, we would like to have $330,000 to do a take-back program. and kind of ducked under the table and thought, we're going to get stuff thrown at us if we just even walk into the JBC and ask that. And they said, that sounds good. Okay, fine. So which is kind of surprising. But we now have this 2 years later. We've ramped up, and it took basically a year of rulemaking because everybody had to figure out policies and procedures at the state level. How are we going to do this? We don't have an incinerator in Colorado that's EPA certified for controlled substances. The closest one is in Layton, Utah. So either we have to figure out in the cost, how do we ship stuff over to Layton and get it there, or figure out how do we do it. And so we issued an RFA and had competition, and there's a vendor now that won this contract. So any pharmacy or law enforcement agency in Colorado can participate in this program. There's limited funds for the number of drop boxes that can be serviced, but the goal of it is to have at least one drop box in every county in Colorado by the end of this year. And we've got 59 boxes in 37 counties now. And we're working our way around, trying to go out to every county and say we need at least one in every county. Obviously, Tri-County, we need dozens of boxes because there's millions of people. But we need at least one in every county in Colorado. So that's what we're working on. You can learn more about this at a website called takemedsback.org. And it describes that program and where to go click and look at the map and see where the closest disposal boxes are to you. You'll start to see in June advertisements running on the major media outlets starting in June. Our PR push will start. We wanted to get enough boxes out there before we started sending people to 2 pharmacies and killing those 2 pharmacies. So we tried to get enough pharmacies on board and then start educating people. In terms of state guidelines, you saw the federal guidelines from the CDC. State also has guidelines. DORA has been doing this since the early 80s. They had what was called the Policy for Prescribing and Dispensing Opioids. Way back when I was in pharmacy school in it's not important. But way back then, they still had this policy. Here's what you should be doing. Here's the things you should be thinking about. So it's not new. The notion of following guidelines for safe opioid prescribing is not new. It's just now it's got a whole lot more attention. The policy is now being revised. The medical, pharmacy, nursing, and dental boards are all working together, doing a lot of listening sessions. Just had a big thing over at the university a couple weeks ago where we got everybody together who promulgates guidelines like workers' comp, the North Colorado Health Alliance, Colorado American College of Emergency Physicians, Kaiser, VA, everybody we could find that has guidelines, got them all together and gave input to DORA to say, if you're going to revise your guidelines, keep these things in mind. And trying to harmonize some of that activity, because the good and bad news about guidelines is now there's an awful lot of them. And which one do I pay attention to, and what do I do? DORA says this, and CDC says that, and ACEP says this over here, and who am I supposed to listen to? And so we're trying to work on that, and hopefully in the next 6 months to a year, come out with some sort of unified guidance and some things like that would be helpful to prescribers to say, hey, who do I need to listen to, and what are the key things I have to do? People think about the DORA quadrig policy that it's law. It's not. It's not a law. There is no statute. They think it's a regulation. It's not. It's not in the rules and regs. It did not go through rulemaking, and there were no public hearings in that way, not in the classic sense of rulemaking. So it's not a law, and it's not a rule, and it's not a regulation. It's a policy that's intended as guidance. But again, like I said, lawyers see that, and they see standard of care written all over. And when it says in the preamble to this document, this is not a standard of care definition. It's explicitly in the document. But, if a lawyer's reading through it, they skip right over the this is not a standard of care part and see it, yes, this is a standard of care because DORA said you should do this. Why aren't you doing this? And that's the attitude that lawyers are taking. So it's just something to bear in mind, where the guidelines are saying and what they converge on. And there's a lot of these guidelines, like I said, from various organizations doing them. National Professional Societies, American Pain Society, ACIP, APAM, ACP, you see them all starting to be promulgated, whether it's everyone from addiction medicine all the way to ACP doing their guidelines. So it's primary care over to addiction medicine. State professional societies have their own federal guidelines, state guidelines. If you've ever seen the Washington State called Agency Medical Directors Group Guidelines, it's like 500 pages of any circumstance imaginable. This is a pregnant woman who's under age 30, who came from the South, has this genetic profile. Here's her pain diagnosis, and tell me what's the algorithm for treating her pain. It's probably in there in the Washington guidelines. They're really remarkable, but it's impossible because they're 500 pages long, and you're not going to be able to find them and read them. But they're wonderful guidelines. They have regional health alliances doing this. San Luis Valley, North Colorado Health Alliance, health plans are doing their own. But none of them is necessary. People ask, which is the best guideline? Which one is validated to produce better outcomes in my patients, or lower the overdose risk, or produce the best function? Which guideline is going to lead to better patient outcomes? Then I really believe docs would say, fine, I'm doing that, because that's linked to better outcomes for my patients. And that's a really good motivator, right? But none of these guidelines, unfortunately, is linked to that kind of evidence. We don't know, is the best answer I can give you, unfortunately. But they're there. And I think you're going to see a lot of debate and discussion and fighting over what are the right things that you really have to do. Because if you look at any of them, really, I've looked at 39 different sets of guidelines, and they come down to a core set of elements that are about 20 things you are supposed to be doing. But that's a lot, because most docs aren't doing close to all 20. And you might be doing 2 or 3. Yeah, I'm doing that one and that one and that one. That's good. Yeah, I'm doing 2 or 3 of those things. Man, I'm supposed to do 17 more things than I'm doing now? In what kind of time? Impossible. You know, it becomes impossible to say I'm going to add these 17 steps to my visit, which I don't even have 1 minute to give you for adding something to do it. So it's very difficult to do all of these things. But really, what are these things? If you listen to Steve's talk, it's what the guidelines have codified, that, you know, the evidence base underneath it is to do these things to appropriately risk assess and risk manage. And that's what they really kind of are. They aren't so much clinical guidelines like algorithms for how you treat or diagnose. They're much more risk management and risk assessment kinds of guidelines. So that's the landscape of what's going on. And unfortunately, it's kind of it drops a lot on you. But hopefully, you know, after Leslie's talk, we will have some little tips and tools near the end for how do you do some of this stuff, so we can talk about the moving from what to how. This is kind of the what part. And then we're going to move from what to how in the last couple talks. So thank you.
Thank you. My name is Ricardo Velasquez. I'm a family and community medicine physician from the southern part of the state. I've practiced in rural settings all of my career, except for brief moments of time. And I joined this group when this presentation was being presented in my community, Alamosa, Colorado. And I've sort of tagged along because I work with the Colorado Echo folks, and the promise was they'll get a marketing person, an educator, and they'll be presenting information in the future, but that hasn't happened yet. So I think it's important information to share with you all, and my experience has been over 3 decades of primary care. I've inherited practices where I thought, why didn't I check to see how many opioid-dependent patients were in the practice? Because I felt that I was leaving and being round-shouldered every day after dealing with them. So this is who I am. I practice family medicine. I've been in an administrative role for the last 10, 12 years. I'm familiar with the inherited opioid-dependent patient panels that you all probably interact with when a practitioner leaves or someone in the community leaves, and all of a sudden they're at your doorstep. And that puts you in a position of needing to do something rather quickly. They're waiting for you to walk in the door and interact with them. And I'm also familiar with the 1990 Under Treatment of Pain Organizational Treatment Standards and how they impacted me midway through my career, because I felt it was a very subjective measurement of pain, and at a very gut level, I felt this is doing more harm than good. So I was an opponent of that sort of practice, but I've learned throughout the years how to sort of create a fair patient evaluation treatment approach to chronic pain, and not criminalize anybody, but also be fair and also keep your eyes open, because you have to be pretty astute to be on top of the scams that exist. I will just say that this background information has been already presented, and there is one slide that I just want to say the fact that the U.S. population is 5%, it's actually 4.5%, but we consume 80% of the controlled substance produced in this world. I leave you with that thought because that in itself is a topic for an evening of discussion. How you put that information together into your practice, into your prescribing practice, I think it's a good starting point to sort of start dealing with this opioid use disorder issue that we're talking about. I worked in the southern part of Colorado, and in the map that Dr. Wright showed, that was a high incidence of mortality due to opioid abuse, and it's a rural area, and so I saw patients and families every day. I come from a pediatric and a family medicine background, so I'm very concerned about how opioid dependence affects a child's developmental environment, and I've seen that over time in my practice. I'm going to describe, how many of you participate in echo pain through the state of Colorado? 1, 2, okay, few of you. Okay, I trained where the originator of ECHO, Extension for Community Health Outcomes, developed the program at the University of New Mexico. I practiced in rural Colorado, so I used that knowledge sharing program so that I could manage my hepatitis C patients, 12 a year, and stay on top of the treatment that was constantly changing, and sort of understand when I needed to refer the patient for further evaluation and treatment. So I have been an ECHO fan from way back, and I felt that ECHO pain being developed in the state of Colorado was an excellent tool for people in my setting, and I think that it would also help in an urban setting. So the Healthcare Policy and Financing, or Medicaid, sponsored, developed, and launched 3 years ago in response to Colorado's opioid epidemic. I'm going to show the program under ECHO pain, but I also want to tell you that in the next few days there's conversations going on with Colorado ECHO, which is going to take over ECHO pain, and you'll need to keep those names and the process in back of your mind, because, you know, what we need now is a constant tool that we can improve on to address the opioid use disorder. But now we're going to see a change from the original ECHO pain to something different. But I think it's very well worth it, because Colorado ECHO launched 1 year ago to provide specialty and other educational support to Colorado practices to achieve the triple aim. But I like that their vision is using the knowledge sharing format of ECHO pain as we see it today, but also moving into e-consult and addressing the issue that e-consult is not reimbursed for. That's an obstacle there. Including telehealth for being able to consult with the patient that you have in your clinic that day is also an important part of what Colorado ECHO is planning to prepare to offer providers. And you also need the option to have a patient seen by a specialist in some instances, and in rather short order. There are obstacles to that, and Colorado ECHO is looking at offering those core services besides the educational knowledge sharing that we have with ECHO pain today. So my experience has been in the San Luis Valley, high prevalence of opioid dependence. 6 counties agreed on a single pain management agreement to address the doctor shopping, which was providing an obstacle to addressing the epidemic. Acute care facilities and the emergency room in the region work with primary cares through information exchange. Over the last 3 years, there's a 22% reduction in opioid prescription units over 3 years. The Colorado Medical Society, School of Pharmacy, clinician leaders, and healthcare policy leaders redesigned the PDMP monitoring program, which I think is an important tool to make your workflow efficient in the clinic, and you heard about that. The practice delegated access to PDMP. So the Echo Pain program through the University of Connecticut, which is a federally qualified health center housed at the University of Connecticut, and they oversee a multitude of satellite clinics throughout the state of Connecticut. They have the luxury of having the Weitzman Institute, the think tank foundation of this community health center, that looks at data and identifies that there's an opioid use epidemic in our clinic system, and they developed the program of Echo Pain to address the opioid epidemic, and their summary and vision when they first started this was that primary care providers are the logical members of the healthcare team to recognize, own, and manage the drug issues that so gravely affect our communities. This program will identify and develop the education and support for primary care providers to accomplish this task. So, did I turn it off? Okay. So, sources of opioid epidemics, emergency department, primary care office are the principal ones, medical specialty, surgical specialty, and hospital outpatient departments to a lesser extent. And that's data from 2003 to 2004. Hasn't changed very much. So, the Weitzman Institute developed Echo Pain, and this is the definition and motivation and reasoning for that that you can read on your own. They partnered with the Integrative Pain Center of Arizona. These are pain specialists like Dr. Wright that have been providing this consultative services for 26 years. So it's a stable group that has vast experience for being a consulting agency to review particular cases regarding pain disorders, and they have a format where they will gather data from a provider. You are advised to provide as a primary care physician and have your behavioral health consultant present with you. That way you integrate behavioral health into pain management right from the start. But it's a virtual classroom where you have twice a month courses that last an hour and a half. Half an hour is general chronic pain topic discussion, and then you present cases and you to this panel of interdisciplinary panel that reviews your evaluation, treatment, and makes recommendations, and refers you to educational resources that might help you. But it includes physical medicine, rehab, behavioral health, pharmacy, acupuncture, and traditional Chinese medicine, amongst other things. Sorry, I keep turning it off. Okay, let's see. Thank you for your help, Leslie. So I was on, go up to the United States map on that one. Thank you. So the Weitzman Institute and Echo Learning Project sort of works with 119 practices. They've had 405 Echo sessions, almost 1,500 case presentations, and they have primary care providers from 20 states. I'll just address the Colorado population that participated. About 80 providers participated in Echo Pain, and they're starting to show a reduction in opioid prescribing rates. There's a higher rate of behavioral health involvement with a case. The forms on the left are the standardized information that you have submit to participate in an echo session. The case presentation involves 2 to 3 cases per session. They're co-presented by primary care and behavioral health. They are also archived, and you get some direction in a HIPAA-compliant manner that directs your further evaluation or treatment on that patient and addresses the hard questions of an inherited patient on benzos and opioids or combination drugs that you're trying to figure out how to manage. So from a provider perspective, what you need is a webcam, computer, iPad, smartphone for end users. All that other stuff has to do with what the echo consulting staff has to have for the equipment, but it's very easy to access it. iPad or smartphone. I've never used a smartphone. Print is too small. The screen is too small for me. They also have an echo buprenorphine session that you can read about, and this is to help the heroin or opioid addicted patients through medication-assisted treatment, and providers that need some information in that area can participate in a particular echo buprenorphine session that also is 2 sessions a month. University of Connecticut also sponsors PainNet, which is a comprehensive 24/7 resource for treating pain and transforming care. It's a consultative format for providers that are from Colorado. You don't even have to participate in Echo Pain. They provide it free to the state of Colorado. Now, when Echo Pain merges with Colorado Echo, I'm not sure what's going to happen with PainNet, so be aware of that. E-consults, I mentioned, that's something for the future in our environment. They worked it out where they have e-consults with the University of Arizona Pain Management Clinic. Their results for 2 years of working with Colorado is the participant satisfaction is high. It's rated 1 to 5, and their scores are 4.8, 4.9. This is a test to see what pain-related knowledge, as measured by the No Pain 50 Knowledge Survey. Cohort 1 pre-echo was 166. Post-echo participation went up to 188. Same with year 2 to a lesser degree, but still an improvement. Pain-related self-efficacy, your understanding of pain management, also increased in a similar manner. Cohort 1 pre-echo was 4.21, and post-echo was 5.08, and the year 2 cohort also improved. Bibliography, if you want to dig deeper into the information from the University of Connecticut. This is an important slide, is that Aggie Erickson, if some of you work for an organization that says, I want to work with University of Connecticut and subscribe to their service, Aggie Erickson is the project director. She is a direct contact that can help you navigate through that process. So as I see it, your options are participate in Echo Pain. It's going to change, or Echo buprenorphine, PainNet, or Pain E-Consult with University of Connecticut, and be on the lookout for the program that is going to transition into Colorado Echo. That's going to include specialty care. I would like to know if there's a single contact person that I can pass this information on to Fred Thomas, the director of Colorado Echo, so that dialogue can start to see what your needs are in this Tri-County area. Yes, ma'am. All right, yeah. And just give me your name so that I can recognize it when we talk about it. Central Colorado AHEC, yes. Thank you. Any questions of me? I hate presenting information when it's in transition from Echo Pain Medicaid to Echo Pain, this program that is being developed. I think it's going to be very good, but it hasn't been finalized. So I don't want to put myself in a position where I'm giving you fake news because it's not really solidified until the coming weeks. One of the things that I did want to mention, though, in the San Luis Valley, some of the clinical things that I thought were very important, and I will go back to that slide because I missed it. It'll just take a second. Okay. Yeah, it was, but really what, San Luis Valley, yes. The information that I wanted to share with you is not on that slide. What I think was really critical is the clinicians got together and they actually agreed that when there's a provider leaving a practice or leaving a practice site, that patient panel be looked at, which can do nowadays with EHR, and create an environment where there's a warm handoff for that patient, as opposed to that patient not having any place to go and there's issues for the provider or the patient. It's just a professional way to address someone that may have a lot of difficulty by going to see someone anew without information exchange. It's professional courtesy. It's a warm handoff for the patient. It's something that I thought was a very good idea. The other thing that I've seen is there's one organization that's developed a template so that you don't have to be looking at two or three different screens to sort of have the information on hand to get through that visit efficiently. And so these are clinicians and IT people being motivated to say, okay, how do we manage this situation and sort of be able to get through our day without having this bottleneck because you're dealing with a new pain management patient that you need to process all kinds of new data, do a thorough evaluation, and engage the patient. I think it's very important to have that discussion amongst yourselves. The other thing that I think was important is the clinicians getting together and agreeing on what is appropriate history-taking, evaluation, examination, and treatment plan that we can all agree on because there's cross-coverage that we provide to each other. And you eliminate the problems from having 10 different approaches to patient evaluation and treatment. So that's all I wanted to say. I'm open for any questions, and thank you.
The first one is the far-reaching. This one's a very focused topic on where we are trying to leave you with some ideas, again, just ideas for tools to be able to do this. So Echo and telemedicine is one set of tools for whether it's education coming to a clinician or sharing a case and doing that kind of a case presentation discussion, grand rounds kinds of stuff, or e-consults. Another way to try to do this, again, disclosures, is to use other kinds of technology. Where we left off before is with the guidelines and the proliferation of guidelines and all the things you're supposed to be doing, right? So those are my last two slides from the last one. And knowing that this is very difficult is the problem. There's 20 things I'm supposed to do. Like I said before, I might be doing a couple of those, but to get up to 20 is going to be super hard, if not impossible, for me to just sort of flip a switch and do it. There are, as the saying is now old, it didn't used to be old, but I guess it is old now that there's an app for everything, but it's true, it's become true, that if you want to do certain things, if you want to do opioid dosing or equivalence, and you want to do rotation, you want to do, I want to convert this much hydrocodone over to how much if I'm going to use a different opioid, you can do that, and find a little calculator to do dosing equivalence. So that's helpful. You can do pain tracking in a variety of ways. There's a variety of pain diaries that you can use with a patient. Say, all right, I want you to track your pain, the intensity of the pain, the location of the pain, the nature of the pain, what the times of day. I want to see how this varies. You measure your functions. There's various apps that you can use for patients that are helpful to be able to track pain and get a more adequate and detailed measurement over time, rather than just trying to do an assessment now, and whether that's weekly or monthly. That's good, but it's obviously better if you're doing the measurement frequently. So there's apps to help with that. There are I wouldn't say there's apps. The best I could find was a spreadsheet. But I misspoke there. But there is a spreadsheet, at least from the guys in Washington. So there's the Mayo Clinic has a tapering algorithm. Stanford is working on different tapering algorithms. Washington State has one, and the VA now has a tapering. I would say it's loosely an algorithm. It's not terribly specific, but there are some now that are being developed. Most of what you see is still very crude. 10% a week. And for somebody who's opioid dependent has been on something for, high dose of oxycodone for a couple of years or whatever, you're not going to taper 10% in a week. It's just not going to work in any way. You could probably taper that person, but that's something at that dose might take a year to taper something, not a few weeks. But people think tapering is a month or two for opioids, and that's just not true at all. So why do people not think they can taper? Because it's largely, impossible in that context to taper somebody that way. So we have to do a better job. There's some guidance, but I think it's kind of minimal that's out there to do it, to help you. So these are what I call, different examples of single spoke solutions. Each of those 20 things you're supposed to do, there's an app for that, which is good. And it's also bad because now we just have 20 different apps instead of 20 different pieces of paper. So the problem is the same. I can't go to 20 different apps. I can't, we just have a digital version of our problem that we had with the proliferation of the Washington State guidelines. But there's at least one example. Ricardo mentioned an example. I'll mention another example of there are solutions now evolving in the marketplace to come up with ways to say, well, I just want to put a patient in here and I want to do all that stuff. I just want somebody taking care of the technology behind me so that I know I'm following guidelines, and I can make sure that I'm following guidelines because that's where I want to be. I know I'm supposed to head that way, but how can I do that without making 20 changes to my practice? How can I make one change to my practice? So there's one solution that is, again, it's just one of many, so it's not a plug, and this solution is now available with no cost to physicians to just start using it. If you want to start using it, just go to this website, opsafe.com, and just start using it. So there's no cost to this. It's not a sales pitch in that way. It's just you can use it or not. But there's a tool available for you to help do this kinds of stuff. And it does all kinds of things. You put a patient in here and you onboard them and put in basic demographic information. So it's the same kind of thing you'd be doing if you're going to do a PDMP check, because the system is going to start doing them for you. But you put in that kind of information and you enter which opioids you are prescribing. The things that you end up paying for is if you want this to integrate with your EHR and pull the information all over from your EHR, you can, pay an integration fee and have that done. But it's a lot better anyway than not being able to have a tool to do a lot of these things. It calculates morphine equivalent dosing for you and shows you on the sort of upper right over there where it says 283 morphine equivalents. It just calculates the morphine equivalents. If you change the drug or the dose, it recalculates it for you all the time. So you don't go to a separate morphine equivalent dosage calculator. You do patient assessments with pain and function and misuse risk up front, and it stratifies patients. It checks the PDMP for you while you're doing this and returns a result from the PDMP. It generates a recommended monitoring plan based on risk and based on guidelines saying, because most guidelines say if the patient's low risk, you do a UDT once a year. And if they're a higher risk, you do them every 6 months or every 3 months, depending on their risk level. And this just generates that for you, so you don't have to think about how often do I do UDTs. It'll just schedule them. And the patient gets an app that they download, again, for free, no advertising, no nothing like that for the patient. And they just see, it's time for your UA. Get to call your doctor's office in the next 24 hours. You're up for a UA. And then you can decide how you want to implement those. But it does all those things for the physician, so you don't have to think, well, what am I missing with guidelines? What am I doing? What am I not supposed to be doing? It just sort of does all those things and displays them on one screen, so you can see over time what the patient's pain and function looks like, and what their PDMP results were. If they're having any side effects, it asks them periodically about side effects. So if they're not having any, great, you won't get notified. Because you're basically doing all the things you should be doing that Steve mentioned, or that the guidelines mentioned, or that Ricardo mentioned, and there's a way to do that and have software doing it for you. So again, show stuff over time in a dashboard format. The thing checks the PDMP for you as often as you want. So you check this the first time, and then you just set it to check it daily, weekly, monthly, whatever. Just set it and leave it alone. And it pings the PDMP for you as frequently as you like. I want to set this for daily PDMP checking for my high-risk patients. Go ahead. And then you can set an alert, so if somebody violates the PDMP, it'll email you, or email your MA, or just whatever. And so you can be doing ongoing PDMP checks with not touching the system ever again. You put somebody in once, so yes, it costs you a couple minutes to put somebody in. After that, the gain is 100% on the PDMP rechecks because you never check it again. You just get an email, John Smith fell off the rails today because the PDMP just got checked, and then you know when that happens today, like right now. So it does this automated surveillance. And why not do that? Because the technology is there to do it. So the company figured, why not do surveillance? So it's not just PDMP checking on demand when you want to. It sets it and does automated surveillance for patients, which is another step up from where PDMPs really are. Because now you have to check every single time manually, or somebody has to check manually. And here you check once. And for a chronic pain patient, all those subsequent checks aren't done by anybody except the system running for you. For no cost to the practice. So this thing, again, more than pays for itself when you're not paying for it at all. It pays for itself. Several lab partners are participating in feeding their lab reports through this, the Tox Lab as well. So it starts to unify all the stuff that you need in one place. Don't go to a separate portal for labs, and a separate portal for the PDMP, and a separate portal if I'm doing risk checking, and a separate portal if I'm doing the pain thing. You got all these potential different portals to check. Then you're back to the same old problem again. 20 places to go to try to get the information I need. I would like to try to have it in one place, if possible, is the idea. Track side effects, like I mentioned. Ask the patient about opioid-induced constipation. It is the most common side effect for patients on high-dose opioids, even moderate dose, chronically. You get over to a certain length of time, incidence of opioid-induced constipation climbs between 40 and 50%. So this asks about them using validated scales. And if you have somebody has opioid-induced constipation, it tells the patient with little APAM videos, what is OIC? How do I treat this without pharmacology by dietary and lifestyle mods? If I do need to treat it and they're not saying they're having results, here's what you can do over the counter. And if you've gone through all of that, sends a message to the doc. It says your patient has OIC. It's refractory to at least self-reported behavior changes and self-reported OTC use. And you've got documentation because the system asks the patient, did you use these things? Yes, I did. Do you still have symptoms? Yes, I do. So you've got all the documentation you need, and we're talking to insurers now about saying, well, that's an automatic prior authorization. So that you'd now, if the patient meets those criteria, fine, and you want to prescribe something for that OIC, you could just go ahead and get a prior auth printed out and just fax it over. So that's another ways to try to make the processes a little easier to do the right things, monitor the things you're supposed to be monitoring. Steve told you, so it's correct. So I always take whatever Steve says as clinical gospel. If Steve says it, it must be true. It's the closest thing I have to clinical gospel is Steve. But it's true, really is true. He knows the literature, but he knows the literature a whole heck of a lot better than I do. And he's right. The most common thing you should be doing is monitoring for side effects. That's the one. So we just ask patients about side effects. But we also monitor patients for things like signs of sleep disorder, basically sleep disorders. People think they're having symptoms of being tired and fatigued and all of that. So I'm not sleeping well, and the med is making me drowsy. And it really isn't. It's people who have sleep disordered breathing, are having apneic kind of symptoms at night, not sleeping well, and having daytime drowsiness. Because they're not sleeping well, because of the apnea, because of the opioid. But it shows up. You measure the quality of sleep. So every month we measure quality of sleep. And if something's bad, we notify the doc. Because that's the early stages of people going into opioid-induced respiratory depression. Almost everybody has sleep disordered breathing prior. Because basically that's what you're doing to yourself if you overdose unintentionally. We keep track of aberrancies. There's a place to just make a little quick note. Oh, the patient said that the deer ate them off the picnic table. Steve's top 10, okay, and put in, look at deer picnic table, click. And just say, all right. But it's basically, because patients, as you know, we'll talk to the physician, then they'll talk to the MA, and then we'll come at a different time and try to talk to the partner. And I'm going to try to spread my excuses around, if at all possible, so that I don't tell anybody the same excuse twice, and I can use each one once on somebody else. And hopefully those people don't talk. And hopefully they aren't putting them in the same place in the chart, because even if they're charting, patients know that you're not going to read back through 2 years worth of chart notes. And you're not. Who's going to? Nobody's going to. Nobody can. So there's an aberrancy log that counts how many times is this happening, how many excuses are they using, and also you can say, yeah, that's the fifth time your grandma died this month, so I need to maybe talk to you about that, about either her or you, one of the two. So then, again, you can get these alerts for people and do risk management. You can just look up among your patients who's had a PDMP violation and do kind of risk management stuff if that's what you want to use it for. Or do settings you can change, because Steve will tell you, I hate the ORT. It's a terrible instrument. I don't want to use that damn thing. So darn thing. Pardon my French. I'd rather use the SOAP or the COM or whatever. So okay, you can go in and just pick a different tool. There's a whole library of tools that you could use, because we're not trying to tell doctors what to use or how to practice. Just automate what you're supposed to be doing. And you pick what you want, and there you go. Patient gets the app, and then they get notified periodically, hey, I need you to fill out this form. And then you come back into a visit and look at the dashboard and see how they're doing. And you don't have to ask all those questions, and most of them get asked in between visits, not on your dime. But you get all the information on the dashboard. So we're trying to automate as much of that CDC stuff, or DORA, or whoever it really is. No matter which guideline set you look at, it's the same 20 things. But look at those 20 things and automate as much of that as possible, so you've only got a couple of things to do. And the distance, like Steve's slide with the goat, the leap of faith, how far do you have to jump into the abyss? It's not the Grand Canyon that you have to jump. You just got to jump over to here. Okay, I got to take one step, and that's not that hard to do. It's still a change. So in practices, that's the very hardest thing. Change practice in any one way is still hard, but it's better. So I just wanted to mention that. So if you want, again, use that thing, download it, use it for free. That's the way the model has gone with this company, is to just get people using the system, to get more people having access to those tools. So that's the message here, is there are tools to try to help you deal with the complexities of all that guideline-based stuff that you're being told to do. And so you can practice just like Steve with handy-dandy, some sort of tool to help you do it. So, thank you, and now we'll have a panel discussion. Or any questions first? Sure. Yep, the physician signs a BAA to authorize the company basically to be a third, one of their 3 delegates to check for the PDMP for them, and says, I authorize you to contact my patient and ask this information that I am specifying. So we're acting as an agent of the physician under a BAA. The patient, when they first download the app, they sign 3 consents: an end user license agreement, a HIPAA authorization, and a 42 CFR Part 2 release. So the patient is fully consented, then can opt out at any time. So they have positive consent and the ability to opt out. So the patient is fully consented. No charge for the practitioners, no charge for the patients. The company is monetizing this now on the margin for things like, if you want to integrate it into your EHR, come in and integrate it into your scheduling system. Or they do additional things like, if you want to track your prescriptions, sometimes you write a prescription, and when you put your opioid in, if you're not doing e-prescribing for opioids, you can click a button and it will issue a tamper-resistant prescription on a regular printer paper, and issue that prescription, and then it checks the PDMP every day, waiting to see if that got filled, and does this reconciliation. And so that's a little upcharge. I think it's $10 or $15 a month to add that feature. But there's other sort of additional features that I didn't mention, is the way the company's trying to monetize now, rather than charging for subscription. So now it's just, if docs want to use it, use it. And you're saving all that PDMP charges and that kind of stuff. The other things they're monetizing are like, there are certain things that are billable in between visits. Every so often you can bill a risk score under a telemed code. Every so often you can bill naloxone education. You can do certain things that you may not know that are billables, of these new things you might not be doing, and the system will track all those things that are billable and give you a report saying, here's the billable event revenue that we think you're generating this month. If you want those reports, you pay a fee. It's not a percentage, just a flat fee on here's what you pay to get those billable event codes per month. But then we're talking about this thing turning into a revenue generator for you. Not the cost to use the system itself, though. The base cost to use the system and be CDC compliant and do all that stuff is free. So it's an interesting thing. Like Practice Fusion, the EHR, if anybody's familiar with Practice Fusion, they do the same thing. The base cloud-based EHR system, same thing, is free. But if you want to do some of these additional things that have value, if you choose to, then you pay for those additional value adds. Same kind of model. Well, thank you.
Sorry, how widely used is this now?
There's about 450 doctors in Colorado using it right now, and about 100 out of state. It's also live in Pennsylvania, New York, and Massachusetts right now, 3 other states. So growing as the footprint grows, but primarily in Colorado right now. You'll see more about this in the fall with Copic. We're talking with them, with Alan and the guys at Copic, with Pinnacle, and with CMS. You'll see a kind of a push that they'll be doing in September, October, sort of a big splash on everything they're trying to do, and this will get play as well, that, hey, this thing is free, use it. Why not? I mean, it's there and free. You can be getting guideline adherence, and there's a little thing that's being added to it now to another tab. You saw those little tabs of information. One of them will show how guideline adherent that patient is based on what you're doing and how guideline adherent you are relative to your peers, saying, oh, I'm 46% guideline adherent. My peers are 62. Maybe I ought to be doing a little bit more using that benchmarking and norming kind of concept that docs are very familiar with, because nobody wants to be the below average doc or below average anything for that matter. So it uses that kind of stuff. Thanks.
I promise we're almost done. We have a brief discussion for you on medication-assisted treatment. Really, it's more of a you can do it, and we should be doing this. And then we'll open it up for questions, and then we'll get out of your hair.
So that's right. Only 6 hours to go. Medication-assisted treatment is a term that's used. Actually, it's not my preferred term. Medication management is my preferred term, and the reason is it tends to situate medication management as sort of second tier. But it's really not. I think that there are 3 approaches to addiction, no matter what kind of addiction we're talking about, and all 3 are equals in terms of how we apply that. First of all, is mutual help programs. We know those as 12-step as well. They're not self-help. They're mutual help. Individuals help each other. Second is addiction therapy, and I prefer that term to counseling and psychosocial. Counseling and psychosocial tends to refer to hand-holding, support, and so forth, but addiction therapy really is all about a variety of very specific treatment processes that are very evidence-based in how they put things together. And then the third is medication management, and all 3 are equal. And what I always did was an individual was identified as having problematic use of a substance, then moving on to a diagnosis of addiction, which, as I mentioned earlier, is compulsion, loss of control, continuation in spite of adverse consequences. I would offer up and say all 3 of these, let's start with those, because we really do not know yet which one might be better than the other and which combination works best. And then over a period of time, individualize that. Within the medication part, there are 3 medications that are currently FDA approved for opioid addiction. First is naltrexone, which is an opioid blocker. It's technically an opioid. It happens to sit on the opioid receptor and do nothing, and therefore it acts as a blocker. Buprenorphine, which is a partial mu opioid receptor agonist. So it gets on, it's very sticky, it sticks around for a long period of time, and it satisfies that push, that craving, and because it sits on for a long period of time, individuals don't have that drive to inappropriately access and use the opioids otherwise. And then methadone, which is a full mu opioid agonist, which sits as a sea of medicine in the whole body, so that, you have this enormous storage of methadone, such that if I go out and use heroin, it's just like a drop in the bucket and doesn't perturb the situation very much. So those 3 medications are available. When it comes to methadone for addiction treatment, however, you need to be a federally qualified program in order to provide that. We as prescribers can use it appropriately for pain, but for addiction it needs to be a separate situation. Naltrexone, fully available to any of us who has a refrigerator and somebody who can do the injections, and it's quite the injection. It's a 4 cc injection about the size of a golf ball, and not necessarily comfortable. Oddly enough, a lot of heroin addicts don't want this injection. What do you mean you've been using needles forever? It's just, but you hear that a lot. And then buprenorphine, which requires a waiver, and we'll talk about that. But I want to pass this over to Leslie, who have her describe how that looks in an office-based setting.
So we prescribe Suboxone. We prescribe buprenorphine to Steve's point. He always keeps us honest. Buprenorphine in a variety of formulations, in a film formulation, in a patch formulation, pills. It comes in a wide variety of formulations. But we use this in the primary care setting inside our federally qualified health center. And I get a lot of questions all the time from other providers going, how on earth do you do that? There's no way we could do that in our practice setting. And I'm not going to say that it's easy. We can't serve everyone. But it is very doable. So in our clinic, in our main clinic, we have 3 Suboxone prescribers, 3 buprenorphine prescribers. And we also have our integrated, behavioral health, providers. Our local community mental health center has embedded about 9 FTE in our clinic. They are employed by North Range Behavioral Health, but they live inside our Montfort Family Clinic, which is Sunrise's largest clinic. Our integrated behavioral health folks evaluate the patient. We get our patients from a variety of ways. We get them from referrals. We get people calling and saying, I am desperate. I'm looking for help, which is unfortunately a very common occurrence. Somebody who's been calling and looking through the internet, combing for someone who will prescribe buprenorphine for them. And we also find them because of our chronic pain management program and the way that we have managed opioid prescribing inside our facilities. We do regular reviews of our patients on chronic opioids and regular aberrancy checking and things like that. And we have found a lot of disordered use inside our opioid monitoring program. So our behavioral health person does an initial assessment and assesses readiness for change and decides whether or not they're appropriate right now, if they're ready. And we have a really low threshold for that. Anybody who comes in really who wants to start on buprenorphine or naltrexone, we obviously can't do methadone because we're not an opioid treatment program. We have a low threshold. So we really try hard to get those folks started. And we can usually get folks started within a week or so. And they come into the office, and so they see our behavioral health person, and then within a week they see a prescriber like myself. And by that time I have my behavioral health consultant's information about their use, and I really can fit this into a 15-minute visit. They are given a prescription. We have an on-site pharmacy. When HCPF switched over to Health First, it was an absolute nightmare to do the prior authorization because a prior authorization is required. But normally it takes like 5 minutes. Our MA gets on the phone, or in the case of our Montfort Family Clinic, our pharmacist gets on the phone and does the prior authorization. We have it within a few minutes. The patient goes to the pharmacy with my behavioral health person, gets that first film, and they take it right there in the office. They sit outside in the hallway, or they sit in the exam room to ensure that they are not going to withdraw. And we then, we do a withdrawal assessment. And after the initial dosing, after about 45 minutes or so, if their COW score has come down sufficiently, and the vast majority of folks are already using buprenorphine from the street. They're buying it on the street. So the vast majority of these folks are experienced patients. So we don't spend hours and hours and hours with them in the office, but we get the occasional person who's never used buprenorphine before, and so for them we monitor them for about an hour, reassess their COW score. If it hasn't come down sufficiently, then we'll dose them again and get them comfortable, and then have them follow up. They see our behavioral health person the next day, and our behavioral health person, it's called medication assisted treatment. The treatment is the behavioral health. And I'm always telling our patients the medicine is the easy part. It really is. I can prescribe buprenorphine all day for you. The water you have to carry is how to go back to your mom when the last time you saw her, you stole her wallet. How do you go back to your wife when she's taking your kids from you because she doesn't trust you anymore? How do you learn to feel embarrassed without reaching for a pill? And how do you learn to sit in those emotions? So the work and the water and the treatment that the water they have to carry in the treatment of medication assisted treatment is the behavioral health. And our behavioral health folks inside integrated care, we do group visits and individual therapy. And that's the way we do it. We have a lot of failures, but our sort of motto is come back when you're ready.
And if I could disagree on one little point, and that is, it's easy. If you're doing pain management, you're already doing the hardest part. And one of the biggest problems with pain management, you never quite know. Is this about addiction or not? When you determine that addiction is what's going on, you know the answer, and it is actually, it's easier than diabetes as far as I'm concerned. And these patients are wonderfully grateful. Saved my marriage, saved my life. I was in North Carolina for a while, saved my truck. I guess that's important. These individuals, and truly, they're very, very interesting. And as you can tell by some of the comments that I've heard over the years, very colorful kind of situations come up. I didn't learn anything about addiction or pain management in my residency, but I did have a attending that told me the way to avoid burnout in medicine is to let your patients entertain you. And oh my gosh, that certainly happens. So I think we want to open it up, or if you have comments on medication management as well. But we want to open up for questions, not only for medication management of addiction, but also in relation to pain management, risk management, which I think is so important.
About 10 minutes left, so and after that we'll all stick around if people have more questions.
So I'm trying to feel hopeful, sitting over here, especially when I think about this at the population level and what's going on broadly. And when I think of the multifaceted approaches that I've heard this morning, or this evening, about how we approach this epidemic, I heard the broad policy/regulatory environment stuff that's going to be continued to be done. That'll be either at the federal or state, kind of level. Then there's all the guideline-ish stuff, du jour, maybe we can all agree someday, and that's kind of a nirvana. And then there's the bedside. Basically I'm hearing those three broad approaches. If this epidemic continues, which it looks like it is, and the medical community, which I'm a part of, is not really making a dent in it. And the number of ads that are on the street are getting out there somehow. 78% of heroin users started with prescription opiates at some point. A lot of people who are using them were not prescribed them. They got them out of the medicine. Diversion is my fear is that this problem will continue unabated, and we as a medical community are basically said, you're not getting it done. And there's going to be something more draconian or whatever. And where's the best bang for the buck to actually, I guess, help me with my frustration.
Sure. No, you're raising that's the real question. This thing is huge, and it's like, and I liken it to like trying to turn around an ocean liner, to try to turn that thing around and go the other way before we crash into the strait up in Alaska and spill more oil. And we are, we're working, at least, the feds are trying to do what they can do. It's getting federal cooperation across agencies. Good luck with federal cooperation. But I think they're trying to do what they can. At the state level, we have this Colorado Consortium for Prescription Drug Abuse Prevention, and we have 9 different levers that we're trying to pull. Some of them are, increasing access to treatment. This is part of provider education. We're doing harm reduction with naloxone access. We can't use the words needle exchange. We can't use the word supervised injection or safe injection because it freaks people out. So we're using the word naloxone because that doesn't freak people out, because it's a near perfect antidote. And so we think naloxone ought to be over the counter, promoting that, because we need to do that. We have provider education. We need to retrain an entire generation of practitioners. We're working with the medical, dental, and pharmacy and nursing schools to change the curricula so they actually contain better pain, diagnosis of pain, multimodal treatments of pain, non-opioid alternatives, and so we're doing that. But that'll only take about 40 years to get the next generation of providers trained. So we need to do it now. We need to make people aware in terms of public awareness about the size and scope of this thing. The lowest of the low-hanging fruit is safe disposal, because there are almost 300 million opioid prescriptions issued every year in the United States. It's enough for every American adult to have a bottle of pills every year. And you put that into the medicine cabinets, and we see what we're doing with take-back, and it isn't anywhere near. We also know from surveys that the average number of people for acute pain, which is about half those prescriptions, will get anywhere from 30 to 40 tablets and take 4 to 6. And so we know there's an awful lot left over sitting in the medicine cabinets. Again, that's why the people report that the number one place they start. So we think the lowest of the low-hanging fruit is pushing very hard on safe disposal to clear all that stuff out of the medicine cabinets and try to stop the non-medical use that's going on in terms of that source, that's the first place to start. But then again, there's all the people that are at super high risk, either using heroin or using super high doses of opioids. Even if it is for legitimate pain management, they're at pretty high risk for OIRD and overdose death unintentionally. Right. 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 Absolutely. And there's the guy that I just met in the last several months that basically had a very promising career as a young scientist, PhD trained scientist, biomedical scientist, became addicted. It's a very typical kind of downward spiral, lost everything, job, family, wife, all of it gone. Now wrote a book, said here's what this, and he wrote a book basically telling you here's how I can show you how to scam just about anything. I can scam the UDTs. I can tell you if I know when they're coming. I know how to take when and what and how to do it. I mean, it's those can be beat. So it's kind of systems. We need better systems to differentiate things like what all those sources of possible issues are. Because you're right, checking the PDMP is good, but if somebody's religiously just getting stuff filled, they may not be taking them. They're just selling them. Little old lady in northern Colorado, we found this out that, had been getting 180 OxyContin every month for 3 years. Nothing in the urine. Confronted, said, yeah, that's how I pay rent. Is that stuff, because that stuff sells good. And so it's a very complicated problem. It's an insidious problem. It's a complicated problem. We didn't get into this quickly, and we're not going to get out of it quickly as much as we hope we can. But the medical community, we think, as doctors, pharmacists, dentists, my brother's a dentist, my dad's a doc, I'm a pharmacist, I think we got all bases covered, all have responsibility in prescribing less, prescribing more judiciously. When you do prescribe it, use the guardrails, do good risk management to make sure someone doesn't become addicted. And if they show signs of it, stop things more quickly. But it's a heavy lift.
I know there's a question up there. I appreciate your question as to how do you get started in the San Luis Valley. The recognition that the primary care provider, the family medicine provider, knows the patient, knows the patient's family, knows the patient's community, has to take the leadership in developing a consortium to start the dialogue in the community. And that's how it started in the San Luis Valley. You got leadership support, pharmacy, clinicians, nursing, and behavioral health. And the conversation and the dialogue started happening to, okay, how do we address the problem? And it took years.
I want to comment. We'll get to your question. In terms of low-hanging fruit, Rob is absolutely correct. We gotta grab onto those things that are obvious, big players, and the volume of material that's out there is a big part of the problem. It's not volume that's being used; it's volume that's out there and just sitting around for the next available interested party. 70%. The other thing is, what's behind the curtain on overdoses? They're not a uniform group of individuals. And, is it my memory problem? I'm taking an extra dose and I die. Is it my horrible pain? I'm taking an extra dose and I die. No, there's actually only 2 studies, which is remarkable. There's only 2 studies that look behind the curtain. And in one study, 80%, the other study, 95%, had addiction characteristics before their death. So for me, the heavy hitter is identify addiction, get these individuals off of standard opioids and into a treatment process in order to make that work. When you look at the PDMP, wonderful tool. I highly recommend doing what Rob is suggesting with the OpiSafe, but it's only 0.7% doctor shoppers, which is defined by 4 or more. That's not going to be where the big money's at. And so identifying addiction characteristics involves the monitoring for behavioral aberrancies, the PDMP, which is going to be a low yield phenomenon, but the urine drug test, which I think is really important. And there's a real absence of the skill set of how to do that particular piece. I think that's where the next opening is. But take the waiver course about buprenorphine, even if you never write it, so that you're able to understand addiction and can identify it and get somebody to assistance with their addiction, even if you never write buprenorphine. But you should. It's easy. It's fun. Question?
Go ahead. No, ladies first.
So it seems to me that a lot of the problem with the drugs in the medicine cabinet is over-prescribing for surgeries, post-op care. And I also think that part of that is that surgeons can't ERX. It's not illegal, but multiple medical systems don't allow it. And what can be done about that? I mean, I know Denver Health doesn't allow it.
Yeah.
I know that where I'm working now doesn't allow it.
It's a tough one.
Why don't they allow it?
It's a really tough one.
The state needs to allow it. There's issues of federal law, there's issues of state law, then there's issues, of systems, then wanting to purchase e-prescribing solutions and then pay for those, because those don't just, they're not free either. None of that is free. Those pieces of technology to be able to do e-prescribing, that costs systems, and to do that, So it can be right, but then state, again, federal law may permit it, but state law has to allow e-prescribing of controlled substances. I don't think we have an e-prescribing law here for controlled substances. Right. And again, that's kind of that's a relatively easy one. But people have tried to identify, where were the 70%? We needed the safe disposal programs. That's what we went to the legislature with first. Sort of those sorts of things. The largest fraction of where the problem was where we went for this. The ability to e-prescribe just wasn't identified as one of the primary drivers of the problem. It's because whether you write it down or e-prescribe it, if you give 10 tablets instead of 30, you've just done a service to somebody. And that's the main problem, is the quantity per script. And those are starting to come down. The average number of tablets per script, the average number of morphine equivalents per script, the curve is bending now and is actually decreasing. That's good news. It's still way too high by most standards, but it's actually decreasing now, which is, so the bow of the ship is starting to move. But that's so was the Titanic. The bow was starting to move, didn't still hit the iceberg, right?
Not a question, more a commentary, and I apologize up front. Any OBs here in the room? Any obstetricians? Anyone from St. Anthony's North? No. So I came down here. I'm the medical director at St. Anthony's North of the OB division, and I didn't think there would be any OBs here. So I thought, you're OB? Excellent. I thought I'd throw my 2 cents in, and feel free to disagree with me. But it's a nightmare with obstetrics. And ACOG, which is our parent organization, and a very political one at that, has certainly issued a response to the CDC changes, and ACOG has rejected the CDC changes. Whenever reality on the ground interferes with the politics of this organization, they choose the politics over the reality on the ground. The data, hear this from one practitioner, the data is very clear that women can be withdrawn during pregnancy and should be withdrawn during pregnancy. there is no increased risk of miscarriage. There is no increased risk of preterm labor. There is no consequence other than a miserable short time period to get them off the juice. If we continue to prescribe to pregnant women and their babies end up in the NICU for 30 days, or 60 days, or 90 days, at $5,000 or $6,000 a day, I don't really even care about the short-term stuff. You know, it's a miserable way to come into the world, diarrhea and puking and shaking and febrile, but it does pass. But the prescriptions that are being written for these women cause permanent neurobehavioral injury to these children. Mm-hmm. So you have to remember, from a primum non nocere, and we put, Dr. Brooks, yes, you're the slide with the doc versus the law and the cops and the judges. We deal with the judges down there because when a baby's born with a positive tox, that's a crime. It's actually not a punishable crime for mom in this state. It is in several states. It's felony in, I think it's Alabama, Louisiana. But at least the social workers get involved. And I can tell you these women can't respond to an intruder. They can't respond to a smoke alarm going off. They can't respond to a fire in the home. So the continued prescribing of narcotics for pregnant women violates every single medical precept that I know. It violates financial precepts. It's destructive in every single way. Yet ACOG still stands behind continued prescribing. And hear this, because I figure this is a group of providers in Colorado. Hear this loudly. They're wrong. The data is clear that the women can get off the juice, and it's our obligation to do so. And that's why I'm so happy you mentioned naltrexone, because it is a gift, and 4 cc's is not a whole lot. It's really not. That's what your bottom is for. That's why it's big and round. And you stick 2 cc's in on each tush, and we welcome the naltrexone coming into our field. But you have to hear that pregnancy is a unique area. And I think, once again, as providers, you have to say, am I damaging this child for the rest of its life to do short-term fix for mom? And the answer is yes, you are damaging that child for the rest of its life. So hear it from one guy. Thanks for putting up with that.
So thank you for that. That's wonderful. If I could, I'm not an OBGYN. I'm a family doc who stopped delivering babies about 1.5 years ago because I don't like being up at 2 o'clock in the morning anymore.
So I hope that's not too
sure. I'm not just saying you are obviously a sweet woman. Part of my issue is on the New York Rip Art, and what the hardest part for me in practicing in Colorado is to realize that everybody out here was sincere, and it took me about 10 years to figure that out. So I understand that you guys all
check that box. Yes.
But once again, the methadone is going to harm.
You know what I will offer is the pregnant addicted patient is no different than any other addicted patient. Their use is disordered, their thoughts are disordered, their view of the world is distorted. And while you can detox them, and I agree that there's robust literature that says that the risk of preterm labor is minimal, the risk of miscarriages is theoretic and academic. But that woman off of her opioid is a dangerous person. She is, if she is not given, and I'm not saying you got to keep giving her OxyContin, what she needs is methadone, gold standard, or buprenorphine, decent alternative. Because if indeed addiction is her issue, heroin is worse for her and her baby. Massive doses of OxyContin from the street are worse for her and her baby. Medication-assisted treatment and behavioral health therapy are what she needs. So I hope that that's not too.
Part of my issue is on the New York Rip Art, and what the hardest part for me in practicing in Colorado is to realize that everybody out here was sincere, and it took me about 10 years to figure that out. So I understand that you guys all mean well, but once again, the methadone is going to harm that child. And I think there were 4 ethical principles that were listed up there, and non-maleficence involves the child, and it is a child. So I was at an ACOG Section 8 meeting 2 months ago, where they gave 3 vignettes, and one was a 26-week pregnant woman that managed to stop her narcotic use for 2 weeks and came into the ER puking diarrhea and febrile and cramping and pain and this and that. And the presenter listed as a success how they initiated methadone and suppressed her symptoms and sent her out on methadone, and she was better. This woman found the willpower to stop. She came in begging for help, and we re-addicted her and permanently damaged her baby. And that is listed as an ACON success. The room had people with their mouths hanging open. One woman clapped in the back. I didn't understand it. We can withdraw these people. If you guys want to Google the American Journal of Obstetrics and Gynecology, it's the Society of Maternal Fetal Medicine Doctors, last year, reasonable study, small numbers, but reasonable study, that there was no increased risk. Now, if we drive these people to the street, and we drive them to heroin, what was listed is, well, they'll get AIDS from needles, and they'll get Hep C. Correct me if I'm wrong, but Hep C is now cured, and AIDS is an individual choice. If you want to go down and shoot up, and you get that, that's your business. But we as providers, and you're not going to like this, but we as providers have no right to harm that child because mom may go shoot up on the street. You're still hurting that baby. We're talking about prescribed narcotics here, not the street people. I differentiate them. And there's an overlap, there's a huge overlap. But I still think it is a monstrous violation of principle number 2 up there to give any narcotic to a fetus. And that's what you're doing. You're giving narcotics to a fetus.
I'm in a little very... No, I understand.
Them later on, and they're not normal. They don't do well in school. They don't get jobs. They don't go to college. That's the effect of the methadone. That's why naltrexone is a gift from above, and we need to use it more.
We do need to use naltrexone more, but I would differ a little bit in terms of, the non-malfeasance is not do no harm, it is minimize harm. And for some individuals, and we'd love it if indeed abstinence would work for individuals in this particular process, and naltrexone actually stabilizes the prefrontal cortex to make that possibility more successful. But just like any other disease state, it's not going to work for everybody, and so methadone is indicated, buprenorphine is indicated. These individuals, it's not a matter of willpower. We know this is not a matter of willpower in relation to addiction. That's one of the things we are now quite certain about. And what actually happens is this loss of control is not better managed by my dialing up a lot more effort in that regard. And so for some individuals, the use of a medication is essential in order for them to be able to sustain and access the range of recovery that we really want them to engage in. And so for some individuals, we can't not use opioids. Yes, there is harm, but we are trying to minimize the harm. Where's the balance point? Clinical decision making, and I think that's best done with obstetricians working with addictionists to find out where that sweet spot is in the least harm situation.
We're happy to continue this conversation, but we are out of time. And I want to say thank you to Dr. Douglas, to Maura, to Dr. Weir, for having us. Thank you for sticking around.